অনেকগুলো দিয়ে দিব চেয়ারটা এখন ওপেন করে একটু পরে কথা বলতেছি শুরু করি না ও অন করছিল চেক করছি ঠিক আছে চলো হ্যাঁ আচ্ছা okay, good morning and may peace and blessing upon everyone. I am Dr. Shukharanjan Das. I am the moderator of today's session, as well as Dr. Arifin Bhai and Dr. Sarwar Jahan Bhai as a moderator with me. Feeling privileged and blessed to welcome all respected faculties, speakers, eminent scholars, and enthusiastic trainees from different countries to the second international conference on pain BSc CCPP 2022 and seventh international conference on recent advance in pain. Hope you will enjoy the mega scientific festival all together at the Pan Pacific Sonargaon Hotel, Dhaka on this 10 September 2022. And these days will be written and remembered with pride and glory in the history of pain management in Bangladesh. You already acknowledged Bangladesh Society of Anesthesiologists, Critical Care and Pain Physician arranged this grand event comprising total 5 hall compact lecture all together, hundreds international pain faculties, pre-conference C-arm guided and ultrasound guided pain workshop, which you have already enjoyed. Post-conference cadaveric workshop will be held first time for pain management in Bangladesh. Pain Award ceremony, Lifetime Achievement Award, most important formation of guideline on interventional pain management with the government and many more. I would like to thank my Honorable President, Professor Devoto Bonik Sir, and Secretary General, Professor Kausar Sardar Sir of BSA CCPP for absorbing all the pain for the development of manpower in this arena of pain management. Respected delegate, welcome to the first session, which comprised 6 presentations, 15 minutes for each speaker, followed by discussion. Now I would like to invite the today's chairs. Today's chair are Dr. Gaurav Sharma sir. He is Associate Professor, Pain and Palliative Medicine, SMC Jaipur, Governing Council member and Treasurer of Indian Society of Study for Pain, Governing Council member of West Zone of Indian Society of Anesthesiologists, General Secretary, ISSP Jaipur City Branch. Our another chair is Dr. Gautam Das sir, MBBS, MD, FIPP, Dean, Indian Academy of Pain Medicine. Past President, ISSP, Past President, WIP, India, Pakistan, Sri Lanka, and Iran. Director, Dorothea Pain Hospital, India. And another chair is Professor Pradeep Jain. He is President of Indian Society for Study of Pain. Now I would like to request Dr. Gaurav Sharma sir to conduct the rest of session.
Thank you. It was a nice starting for the very good session. And without wasting any other further time, I would like to invite our first speaker of this session. I would like to welcome Dr. Honorio T. Benjan. He is Professor of Anesthesiology, Northwestern University in Feinberg School of Medicine. He is also Executive Section Editor in Chronic Pain Medicine, Anesthesia, Analgesia. He is a past chair in WIP USA. He will present his thoughts on safety issue with the use of contrast agent in interventional pain procedures. So I would like to invite Dr. Benjan. Thank you.
Good morning. Greetings from the beautiful city of Chicago. I will be discussing the following adverse reactions from contrast media, including the gadolinium-based contrast agent and the iodinated contrast agents. Then I'll be presenting the statements and recommendations from a multinational, multi-specialty, multi-society practice advisory that we published last year. So why do we use gadolinium-based contrast agents? If a patient has a history of a hypersensitivity reaction to iodinated contrast medium, then we switch to a gadolinium-based contrast agent. The reason for this is that the incidence of immediate as well as severe reactions is a lot lower with the gadolinium-based agents compared to the iodinated contrast agents. What about the diagnostic accuracy? Well, it's not as good as the iodinated contrast agents, but it's good enough to allow confirmation of the location of the needle tip as well as the spread of the contrast. So this table is a list of the gadolinium-based contrast agents. The important things to know are the following. The concentration of the gadolinium is the same in most gadolinium-based agents, except in two agents wherein it is half the usual concentration, but we don't use this. These agents are used for liver MRIs. On the other hand, the dobutrol has double the concentration of gadolinium ion compared to the other gadolinium-based contrast agents. Don't worry about the ionicity of the gadolinium-based agents. The important thing is that the gadolinium ion in the linear gadolinium agents is loosely attached to the structure, while in the macrocyclic gadolinium based agents, the gadolinium ion is caged inside the molecular structure of the ion. Therefore, the gadolinium ion is easily released from the linear agent, and it has difficulty being released from the macrocyclic agents. The adverse events are secondary to the gadolinium ion because the gadolinium ion is a lanthanide ion, hence it is a toxic ion. So we presented this practice advisory. I just want to spend a few minutes on the grading system of the USPSTF, United States Preventive Services Task Force Grading of Evidence. Grade A means the recommendation is sure to provide substantial benefit. With grade B, the benefit is moderate, whereas with grade C, the benefit is small and applies only to individual patients. Any recommendation that is a negative recommendation, do not inject, avoid using this contrast, automatically requires a grade D, no matter how important the recommendation is. The practice advisory was based on the literature, and the existing literature relates to intravenous administration of large doses of iodinated contrast medium or gadolinium-based contrast agents. We're talking about 50 to 100 ml injected over a few minutes, 3 to 5 minutes. whereas in interventional pain procedure, 3 to 5 ml at most is injected extravascularly. In nephrogenic systemic fibrosis, the gadolinium ion escapes from the molecular structure. It is absorbed by the macrophage. The macrophage ruptures, releasing the gadolinium ion, which then stimulates the development of pro-fibrotic cytokines. This results in renal failure if the fibroblast occurs in the kidney, and the systemic manifestations include this ugly looking stiffness, induration, contractures of the joint, resulting in difficulty walking of the patient. Statements and recommendations. The macrocyclic gadolinium agent can be administered in patients with chronic kidney disease stage 3 and stage 4. However, the macrocyclic and especially the linear agents are contraindicated in chronic kidney disease stage 5, hemodialysis, and those with acute kidney injury. If you have to use a contrast, then the iodinated contrast agent can be used instead of the gadolinium-based contrast agent. The second topic is gadolinium brain deposition, what some experts call it brain retention. Chuck Norris, a well-known Hollywood actor, stated that his wife, Jenna, was never the same after she was administered gadolinium-based MRI. There are some depositions in the globus pallidus, as well as in the dentate nucleus. An autopsy study showed that the deposition was indeed gadolinium ion. And the more gadolinium ion is administered, the more gadolinium ion is released, and there is increasing deposition of the gadolinium ion within the brain. So several societies, including this international society, summarize the statements and recommendations. It does mostly occur after linear gadolinium-based agents, but can also occur with the macrocyclic agents. To date, there are no clinically harmful effects from the gadolinium brain deposition. If you look at this large study of 246,000 patients, the rates of Parkinsonism was the same in patients who had gadolinium enhanced MRI. Incidence is 1.2, incidence of Parkinsonism, versus those who had non-contrast MRI. A study showing some cognitive symptoms in 132 patients who had gadolinium-based contrast agents was questioned because they considered the cognitive symptoms as a component of the nephrogenic systemic fibrosis. So we stated that gadolinium deposition is higher with linear gadolinium agents compared to macrocyclic agents. However, there are no clinically harmful effects of the gadolinium brain deposition at this time. If we see patients who had 2 or 3 gadolinium-based diagnostic MRIs, then we should be aware of it and note them in the record, because gadolinium brain deposition has been documented even after 2 or 3 gadolinium-based MRIs. There are a subset of patients, those who had hydrocephalus, those who had brain tumors that would have serial MRIs, and then would have serial gadolinium-based contrast MRIs. The third topic is encephalopathy or death from intrathecal gadolinium. There have been proposed mechanisms, but none of these have been really properly investigated. There are several case reports of encephalopathy, seizures, agitation, cardiac arrest, intubation, after unintentional injection of 3 to 5 ml of intrathecal gadolinium. The patients either had a full recovery or one patient died. It's hard to see the gadolinium ion in the CSF, but you can see the cytotoxic edema in the parietal lobe as well as in the temporal lobe. We ought to realize that our radiology colleagues inject gadolinium intrathecally when they study the glymphatic system. The glymphatic system is the one involved in draining toxic materials from the brain. And some experts believe that problems with lymphatic drainage is probably one of the reasons in the early development of dementia or Alzheimer's. So there's a fair amount of studies going on. But in a study of 100 patients, 0.5 ml gadolinium was injected but diluted with 3 ml of an iodinated contrast medium. There were really no adverse events. One patient had an anaphylactic reaction, but that patient had a known allergy to contrast. Some had headache, but that might well be a component of postural punctual headache. So our radiology colleagues do inject intrathecal gadolinium, but they do not exceed 1 ml compared to injecting 3 to 5 ml epidurally unintentionally when we do interventional procedures. Our radiology colleagues inject diluted with CSF, saline, or another contrast media, and inject it very slowly. So we do not recommend the use of gadolinium in interlaminar as well as transforaminal epidural injection. When the risk of intrathecal injection is extremely low, then we can inject intrathecal gadolinium. However, the lowest possible volume should be injected. The last topic is hypersensitivity reactions to contrast medium. 92% of hypersensitivity reactions are anaphylactoid reactions or non-IgE mediated reactions. Acute reactions occur within 20 minutes. Late reactions occur within 1 hour, maybe delayed up to 4 to 6 hours, rarely up to 1 week. But if they're not going to happen within 6 hours, they probably will not happen at all. Again, the incidence is less with the gadolinium-based agent compared to the iodinated contrast agents. And the occurrence of a reaction to the contrast agent in interventional procedures is very, very low. So a summary of numerous studies on the hypersensitivity reactions to contrast medium. The occurrence of a repeat reaction is significantly decreased when the identified culprit contrast medium is changed. It's actually more effective than doing pre-medication. The lack of uniform efficacy of pre-medication is the reason that pre-medication is not uniformly used in Europe. It's controversial in Europe. When the previous reaction is moderate to severe, then the patient should ideally be referred to an allergist. The important thing to realize is that the occurrence of a breakthrough reaction in a patient with a confirmed previous reaction is very, very low when given extravascularly. 6 patients over 25 years at Northwestern, they were intentionally injected with the same contrast that they had the reaction to during a diagnostic MRI, did not develop any reaction at all. This was the same finding in the study from Korea. 20 patients who had extravascular injections of the same culprit contrast medium. They were given during fistula, outlining the fistula, intraperitoneal injection in the common bile duct or the biliary system. None of them developed a breakthrough reaction. This may well be secondary to the small amount injected or to the epidural steroid that's also injected with it. So most reactions occur within 20 minutes. Late reactions occur within 1 hour to 6 hours. But breakthrough reactions after an extravascular injection is very, very low. So what do we recommend? When you change to a different contrast medium in patients with mild reaction, you may treat with steroids, but the steroids can increase the blood sugar by 20 to 120 milligrams. Moderate to severe reactions, you pre-treat them. You change the iodinated contrast medium or to a gadolinium-based agent. Pre-medication for late reactions is not recommended. We feel that 30 minutes is adequate for duration of monitoring in patients with mild reactions or even those with moderate to severe reaction, but no reaction within the first 15 minutes. Summary conclusions, we ought to realize that linear agents are associated more with nephrogenic systemic fibrosis and gadolinium brain deposition. The clinical significance of gadolinium retention in the brain is not known, and encephalopathy or death can occur from intrathecal injection. And again, as I said, breakthrough reaction is rare when a small amount of the culprit contrast medium is injected extravascularly. Those with kidney function, we prefer that you use macrocyclic gadolinium if you're going to use a gadolinium-based agent at all. We ought to be aware of patients who have 2 or 3 gadolinium-based MRIs. We recommend that you do not use gadolinium when the possibility of intrathecal injection is there, and that emergency equipment should, of course, be available. So thank you so much for inviting me. It has been an honor and a privilege to speak before you too.
Thank you, Dr. Benjamin. It's a nice summary and nice review of the status of and safety issue of this contrast agent. Thank you very much. Now we move to our next speaker, Dr. Amitabh Gulati. He is presently president of World Academy of Pain Medicine in USA, and he's past vice chair of WIP in US, and presently is working Department of Anesthesia in New York. His topic is intrathecal drug delivery. So I would like to invite Dr. Gulati to please have a good session.
Hello, everyone. First off, I want to thank you for our colleague, Dr. Sardar, and colleagues in the Bangladesh Society for giving me the opportunity to chat with you about some options for medications for intrathecal drug delivery. I'm Amitabh Gulati, president of the World Academy of Pain Medicine United, and member of the World Academy, World Institute of Pain. I work at Memorial Sloan Kettering Cancer Center in New York City, and I'll be sharing some insights into how we use intrathecal drug delivery for our cancer patients primarily, but really these principles can be discussed for any form of complex pain syndromes. These are my financial disclosures. I really want to focus briefly on cost utilization, which is more relevant for the United States. Obviously, these devices are very expensive, and you have to have a cost-benefit analysis in whatever situation, regardless of the country you're in, when we're thinking about implanting these devices. Talk more commonly about intrathecal medications, some of which may be more readily available in Bangladesh and in the surrounding area, and then some dosing suggestions. When we think about intrathecal drug delivery, the primary benefit is the reservoir or the pump houses either 20 milliliters or 40 milliliters of solution, but it can be delivered at very, very, very slow flow rates. So 0.2, 0.3 milliliters a day through a small catheter. That catheter is in the intrathecal space, and because of the low flow rate, it really does not disrupt the CSF, which is primarily stagnant in most of the locations in the neuroaxis. And you deliver the tiny amounts of the medication, which will diffuse slowly into the spinal cord and or the surrounding rootlets. And from there, that you can have the effect of the medication that may relieve into pain relief without having systemic side effects. So indications include patients who are having uncontrolled pain with anesthetics systemically or opioids, etc., or are not tolerating their medication, systemic pain medications such as constipation from opioids systemically. We do see that these are expensive devices. We expect patients to live a certain amount of time so they can have benefit from a device from a discussion of cost and benefit analyses. Our seminal trial was in 2002, so 20 years now, really showing that in cancer patients that compared to optimizing medical management, morphine and adjuvants, and comparing patients who are malignant disease to patients who received an intrathecal pump, both patients had an improvement in pain scores, a little bit more robust in the intrathecal drug delivery group, but however, significant decreases in toxicities related to systemic medications, primarily opioids. So fatigue, confusion, depression, constipation significantly improved relative to making modifications of the systemic drug regimen by mouth. We found in the early data, those patients tended to live a little bit longer if they had an intrathecal pump implanted. That may be because of better nutritional status, being more awake, and so you had the ability to keep nutrition and exercise, etc. So without further analysis, there was some benefit. In the United States, our late and great Dr. Lisa Stearns did some good evaluations of patients who received intrathecal drug delivery, and at least in the United States, show that intrathecal drug delivery devices implanted reduced office visits relative to conservative medical management, reduced outpatient hospital visits, and a little bit improvement in length of stay over time. And that was a big benefit. There was some reduction in costs. You've seen less use of antidepressant and anxiolytics, decrease in systemic opioids. So there's a cost benefit as well in terms of systemic pharmacotherapy. Now, clearly, there is an impact of the actual medication that's compounded intrathecally and the actual cost of the device. And at least in the United States, it seemed like at least requires 6 months or so of after implanting a device for the cost of the implantation of the device, as well as the compounded medications to be less expensive than conservative medical management, systemic opioids, and the visits associated with coming into the hospital. So over time, there's a benefit to having an intrathecal pump. Clearly, in different economic situations, that benefit may be longer. But in the United States, roughly 6 months is a telltale sign. There's some drug regimens in the United States that Dr. Brogan and colleagues in Utah discussed that are more expensive than others, and therefore there's a cost benefit to having an intrathecal pump and removing those medications. In our case, intravenous patient-controlled analgesia or IV PCA with opioids given intravenously, transdermal fentanyl, or extremely high doses of systemic opioids are very expensive, and therefore a implantation of an intrathecal pump by around 7 months shows that it is cheaper to place a device and then use their pump medications as opposed to using the systemic opioids of these high regimens. Clearly, if you're using methadone, oral morphine, these medications are less expensive, and there may be never a time where the cost-benefit analysis supports the use of an intrathecal pump, and really looking at quality of life assessments that improve the cost-benefit ratio in these cases. Over the years, there have been a significant number of studies in oncology, really showing from multiple groups the benefits of intrathecal drug delivery. Our group at Memorial Sloan Kettering showed that bupivacaine plus opioid plus or minus a clonidine regimen significantly improved systemic opioid use by decreasing opioid use by 74% in 4 days that remained sustained. So we have a regimen in place to place an intrathecal pump and reduce our systemic opioids very quickly over 4 days during inpatient admission. We usually have an equal analgesic dose of opioid running in the intrathecal pump or a little bit less than systemic dosage, such that there's very little likelihood of opioid withdrawal. Dr. Brogan and Dr. Sint's group in Utah, very similar results, discontinue opioids very quickly. Instead of their third adjuvant medication is zaconitide as opposed to clonidine. And we have multiple, Dr. Stearns, Dr. Syed in Kansas, and so on, showing good results of intrathecal drug delivery really benefiting patients. We do have guidelines in the literature, primarily supporting neuropathic and nociceptive pain, but also some focus on cancer or pain. But in reality, most of the data from the PAC guidelines, the polyanalytic conference, really is focused on showing the benefits of first-line agents such as zaconitide and morphine for neuropathic pain or diffuse nociceptive pain or localized nociceptive pain, and giving you regimens that might be beneficial in drug choices. For oncologic pain, we tend to be more liberal in our choices for medications. We'll discuss that in a few slides. The beauty of the PAC guidelines is really to discuss starting dosage regimens, maximum dosage concentrations in the pump, and rates, really to control these possibility of intrathecal side effects such as granuloma formations. So they kind of go through the different choices of medications. Clearly, in the oncologic setting, many times we'll be using compounded regimens, which we'll discuss. There have been some other medications used, though not nearly as common as the ones listed on the left side, such as morphine, hydromorphone, tend to be the most common opioids. Fentanyl tends to be another opioid that's used. Bupivacaine tends to be the very common second or first adjuvant in addition to the opioid, but we've seen clonidine, sufentanil, and zaconitide. Even though it's first-line agent, there's some costs associated with this. So while it's a very good medication, it can be difficult to actually have it reimbursed in both the United States and abroad. Switch gears to medication choices really quickly, because I know I have very few minutes. We've had good data in the literature showing that different opioids have a different effect in the intrathecal space. In general, the more lipophilic, the more the drug likes to be around fat and less in the water, the more likely it's going to leave the central cerebral spinal fluid and diffuse out the arteries or the epidural space and become systemic. So sufentanil and fentanyl tend to be more systemic than morphine or hydromorphone. That also means that drugs that are more hydrophilic, morphine or hydromorphone, tend to stay near the catheter site. So what this is showing here is that as you get further away from the catheter site, the concentration of the opioid, specifically morphine in this case, precipitously drops. Really illustrating that CSF, the cerebral spinal fluid, is not mixing, but very stagnant around the spinal cord. And really the motion of the pulsations of the arteries and the veins and some pulsation of the bones as you take a breath move fluid in and out, and that's the motion that causes movement of the CSF. As a result, a slow infusing pump really gives a infusion of medication that's so slow that it basically diffuses out of the catheter, and therefore you're dependent on the diffusion gradient of the drug spread through the CSF. Different pumps may have different velocities of injectates. You may use velocity of a drug to overcome just diffusion properties of a drug. But in the end, CSF does not move very much, and the catheters are very low flow rates, and therefore diffusion of a drug into the CSF down a concentration or electrical gradient is how these medications transfuse through the CSF into the spinal cord. This is Dr. Flack's work now looking at a and pig model that's vertical, and showing that with an intrathecal pump running at 0.48 milligrams a day, catheter T11 within 5 to 10 centimeters away from the catheter tip in the spinal canal, the morphine concentration has dropped by a factor of almost 10,000, 1,000 to 10,000, so 1 10 to the third or 10 to the fourth less morphine, 3 or 4 vertebral body levels away from the catheter tip as opposed to at the catheter tip level. That's what a slow flow rate means. With stagnant fluid, most of the morphine will be at the catheter tip. Because of this properties I've discussed earlier, morphine, which is approved in the United States, some forms of it, the concentrations tend to be anywhere from 20 to 60 milligrams a day, depending on what the pharmacy can compound. There are some ratios to convert oral opioids to intrathecal opioids. We tend to be a little more aggressive now. I have used a ratio of 100 to 1 by mouth PO to intrathecal morphine. But as you become more opioid tolerant, more methadone in your system, these ratios tend to break down, and you basically give enough opioids to prevent withdrawal. Similar concentrations for hydromorphone. Both these medications have been fully associated with granuloma formation around the catheter tip. So we encourage higher flow rates and lower concentrations with intrathecal pumps to hopefully prevent the formation of granulomas. Fentanyl and sufentanil, they tend to diffuse through the CSF into the epidural fat or into the systemic circulation through the arteries and veins around the spinal cord, and therefore it acts a little bit more closer to IV doses. And so you'll see regimens in 25 to 100 micrograms per day initiation, and sufentanil 10 to 25 micrograms a day initiation. So we're getting closer to its IV dosing when it comes to opioid use. Very uncommonly is methadone being used these days to the opioids. There's been such excitement for many years about the use of ziconotide in the intrathecal space. As a drug itself, it does stop conduction of neural signals by stopping the initiation of the signaling cascade between the second order and a first order neuron by stopping the influx of calcium. So it can stop the conduction of nociceptive pain transmission. The unfortunate aspect of ziconotide is it has to be titrated very slowly and really focus on the location of these neurons, because technically speaking, there's a ziconotide will stop first order to second order neuron communication of any nerve. It's not specific to pain. And so from where it's come from in an animal, in a snail, it's very useful to make a fish paralyzed. However, for us, we had to be very slow in this titration. We had to put it posteriorly and hope that it works at low concentration. And instead of giving a consistent dose of ziconotide, many people are not giving a dose, or they're giving just boluses of ziconotide with their bolusing devices. While it does have a poor therapeutic window, it's a very good medication in patients who can tolerate the drug. Now, people don't tend to get more tolerant to it over time. There does not seem to be a tolerance associated with ziconotide. It does seem that if it works well and you can tolerate the side effects, then you have a very good pain medication. There's some urinary retention and ultramental status, and really psychiatric disorders and confusion that are associated with ziconotide. So those kind of things you have to worry about. Any patients where you have these kind of issues, maybe a drug you're trying to avoid. We have good evidence from the literature. Dr. Peter Stas's original work really showing that both for HIV and cancer patients, neuropathy patients, they really benefit from ziconotide. What we learned in this study is to slow down the infusion considerably and slowly titrate the medication, so you can reduce the eye side effects. So that's what we've done now, hovering between 0.5 and 1 microgram a day infusion, or boluses that equivalent of 0.5, 0.4 micrograms at a time, twice a day. Something to that effect have been very helpful for patients to tolerate the medication with good pain relief. Ziconotide is a peptide. You can add it with other adjuvants such as intrathecal morphine. The drawback obviously is that as you put a peptide together with other solutions and other drugs, it can degrade a little bit faster. So you need to know the degradation rates of compounded medications in general. By and large, by 3 months, most of the compounded medications have some degradation of the solution. So you want to replace these drugs in a few months time frame, regardless of how much is left in the reservoir or the pump itself. What we see is that as you add ziconotide to a morphine regimen, patients had improved pain scores. And this is related to the patient with bone disease. So really, you'd have to increase the morphine, which add a second drug, in this case, is a aconitide, that seemed to help with pain relief in the oncology population. Our colleagues in Europe and Italy aggressively used ziconotide and really saw benefit in the cancer patient as well. There were some side effects, and we've learned since then to reduce the dosing strategy. And even in oncology, we tried to use ziconotide, probably not necessarily as a first-line agent unless the patient's going to live a long time, but really as an adjuvant agent in lower doses to supplement a morphine or morphine plus local anesthetic regimen as a third or second-line medication. That does not mean they can't tolerate ziconotide as a first-line agent intrathecally. It just means that it's a drug that takes time to titrate. As a result, we need a disease that is either stable or not really worsening very quickly, because you may choose a different drug at that time. Here we have the association with morphine, ziconotide, and levobupivacaine. And you see the same thing, the side effect profile in decreased to 10% roughly from 30% from the other trial. And you have good evidence of pain control. When it comes to local anesthetics, we have good old literature supporting high dose bupivacaine being used even as high as an intrathecal catheter at C1, C2 for head and neck cancer patients, and high rates that patients can tolerate a high flow rate of bupivacaine. So that's very important for us because we're personally are very aggressive with bupivacaine ourselves. We see is that, you know, a milligram an hour, so it can be 24 milligrams a day, is a substantial dose of bupivacaine. It does seem to make a difference, and you can even place catheters at C1, C2, and get good pain relief. In their data set, saw dramatic improvements of pain with the use of local anesthetic for cancer-related pain. We believe local anesthetic is very helpful for cancer-related pain as well, as long as you can tolerate the side effects associated with urinary retention, numbness, or wherever the local anesthetic is placed in the intrathecal space. Initially, we used to think that morphine to the local anesthetic ratio is very important. I sort of have begun to treat these drugs independently of each other. You dose your morphine primarily to supplement the to replace the oral opioid into the intrathecal space. The bupivacaine, I think many people are hovering between 1 and 3 milligrams a day. Our group tends to be more aggressive. I might describe that in the next slide. But regardless, adding bupivacaine at some value relative to morphine makes a big difference in your pain scores, as this shows over here. And there's a lot of benefit from improvement of adding local anesthetic and the opioid together. The ratio that people might tend to say is 1 in 10 of morphine and bupivacaine. My feeling is it's a little bit, they're more separate, and you just calculate the compounding concentration after the fact of what concentration of the drugs you need in the intrathecal pump. In the end, bupivacaine does help with pain control and reduces the use of morphine and among other opioid medications. So in oncology, bupivacaine plus an opioid has to be the first line agent, unless we know a patient can tolerate an opioid, but the main failure is because of side effects. Bupivacaine, similar to morphine, does spread near the catheter tip. So if your catheter tip is posterior and at T11, then chances are your local anesthetic will also be posterior and anywhere from T9 to L1, L2. This is on both in vertical and horizontal pigs, and using, again, the same intrathecal strategy of placing a catheter. What matters again is for the use of bupivacaine and for the use of an opioid such as morphine or hydromorphone, the location of the catheter relative to the spinal cord is of utmost importance, because that's going to tell you if the drug is staying most at the catheter and you want your drug to work at T6, pain and spinal thalamics, then you need to be prepared to put the catheter at the same location with the low flow rates of morphine and or the other medication you may be choosing, which is bupivacaine. As a result of this, bupivacaine tends to be our standard medication for cancer patients. We choose our catheter tip location based on where the exiting rootlets are for bupivacaine, and also the second order neurons, descending inhibitory neurons, are in the spinal cord for the anatomic location of where to place the catheter. In general, for the brachial plexus, we tend to be middle cervical plexus 3 to 5. Arm is similarly 3 to 5. breast can be a little bit lower, the catheter tip can be a little bit lower, T1, T2, and so on and so forth. As you can see, we're trying to define different locations based on where the pain syndrome is. We are aggressive with our bupivacaine dose. Our practice is really 8 milligrams a day of lumbar, of the catheter-based lumbar. And then as you get to the cervical spine, there's a little bit of a decrease in the milligrams per day of bupivacaine. If you're in a private practice or your comfort level is not such like how we are at our institution, clearly you could reduce all of these doses as a initial starting dose and get used to the medication in this population. There are some reports of bupivacaine tachyphylaxis. So we use ropivacaine in the past to not have patients suffer from the loss of effect of bupivacaine. This is some good data showing the transition from ropivacaine to from bupivacaine to ropivacaine. You tend to have a slightly different dose of ropivacaine, around 20% higher than bupivacaine, but nonetheless, that's the benefit of ropivacaine to help with tachyphylaxis of bupivacaine. In end-of-life scenarios, intrathecal ketamine, there were some reports of toxicity in a small animal model and the rabbit model, really just 2 rabbits being injected with intrathecal ketamine. But there is a history of damage to the spinal cord as a result of intrathecal ketamine. So at the end of life, when you know other medications that are working, we would highly consider ketamine as a potential treatment option. It tends to be an agent that's 3rd or 4th line, along with bupivacaine, morphine, clonidine. So that's how people tend to use this drug. In the epidural space, we tend to have a small amount of morphine and ketamine, and we find that there is some relief related to this. So, like the short answer to the use of ketamine is that it's reasonable to consider ketamine at 5 milligrams a day, 10 milligrams a day, and it's reasonable to assume that ketamine is unlikely to affect your spinal cord, but maybe a good adjuvant medication for pain control. Similarly, clonidine was studied early on in the middle 90s, really looking at a subset of patients who received an intrathecal pump because they had clonidine in their pump. What we found was that the addition of clonidine to an opioid regimen or an opioid plus a local anesthetic made some significance in improvement of pain. Our starting dose tends to be 25 to 50 micrograms an hour intrathecally. This is probably more, it should be a day, not an hour. So 25 to 30 micrograms a day intrathecally daily. That tends to be the starting dose. I haven't seen too much sedation with this or rebound hypotension or rebound hypertension. There are some reports from Dr. Casasola and colleagues using high dose clonidine as the original starting dose to avoid some of these blood pressure changes. Dexmedetomidine can replace your clonidine if necessary. The data is fairly good to show some efficacy with dexmedetomidine versus morphine by itself, though not significantly but not necessarily significantly clinically to support this. I know we're a little bit short on time probably. I do want to spend a little bit of time to give a couple of slides on how we do our calculations. We know that intrathecal pumps run really well at 0.2 milliliters to 0.5 milliliters a day. That's your starting rate for most people. For most people, the starting rate is 0.2 milliliters a day, sometimes 0.25 milliliters a day. You probably do not want to go to a flow rate of 1 milliliter a day. If you have a high dose opioid patient, you want to consider a 40 ml pump so you can give you enough opioids so you don't have to come back for refill every few weeks. It's good to choose a rate first, usually between 0.2 and 0.3 mLs a day, milliliters a day. Then pick your initial opioid in milligrams a day so you can choose that ratio. So if you want to give someone 1 milligram a day of morphine, then you know that your pump has 20 milliliters, so you're going to get 20 milligrams of morphine in the per milliliter in the intrathecal pump. So this is how you do the math. Once you choose your ratio, our bupivacaine tends to be anywhere from 6 to 10 milligrams a day, but most people err between 1 and 3 milligrams as a starting dose, especially in a private practice setting. When you convert your opioid, you know that how much morphine or how much morphine equivalent you're using, divide by the concentration of the drug in question. Sorry, you divide that with the flow rate, you get your concentration of the drug at milligrams or micrograms per milliliter, as shown here. The Bupivacaine you arbitrarily choose your starting dose 6 milligrams a day, and the flow rate is 0.2 milliliters a day, and these days will scratch out, and you'll get 30 milligrams per milliliter related to the use of that drug. So there's really good example of math here, how to kind of come through and figure out how to order the drug medications. We will say that one of the benefits of the intrathecal pump has been the use of the bolusing ability of the intrathecal pumps. A lot of the patients like to get 10% of their daily drug as one bolus, usually about 8 times a day, sometimes every 3 hours. And what we saw in Dr. Rogan's work again is that this really benefited patients, and they less chance of coming back and less chance of having previous breakthrough medication. They could give themselves the extra bolus that they needed to for pain control. With that, hopefully it was not too quick for you. Thank you very much. Hopefully one day I'll be able to see everyone in person. We'll be safe and have a wonderful fall and holiday season. Thank you very much. Bye-bye.
Thank you, Dr. Gulati. Thank you for a nice presentation. And now I would like